Hello, class of 2020. I am Matt Miles. Yes, even though I look a little bit different than you may remember, I have now an N95 approved beard. So there you go. I know this is not how we thought we would find ourselves at the end of medical school, but this is where we are, living through a historic time. So I hope you'll appreciate and be okay with the fact that we're going to do our capstone course a little differently. For the past several years, I've had the privilege to speak to your group, the group of graduating students, about effective consultation practices. And it's my privilege to be able to do that again. I hope you'll find this short talk to be beneficial. And so why don't we get started? First, we want to ask the question, why call a consult anyway? I know you've all done this several times during the course of medical school, but let's talk a little bit about the concept behind this. And to illustrate this, I want to give you a theoretical example. This year, July 3rd, 2020, is the first Friday of your intern year. So imagine yourself in this scenario. It's around 4:30 in the afternoon on that Friday, and you call the ICU fellow because you've got a patient who's been having dyspnea, been having some trouble, maybe all day long, and now you're thinking that you may need to admit this patient to the intensive care unit. You call the person, they answer, and you say, "Hi, and then you're just rudely interrupted by the fellow saying, "I have to sign out in 15 minutes, make this quick." So let's talk about what is going on in the process of consultation and find out good ways to approach this that are going to be the best for our patients and also for ourselves. Remember, consultation is not the same thing as a handoff. You're going to have handoffs frequently as part of modern medical care. A handoff is really when you're exchanging the primary care of a patient from yourself to another person, right? So you come in for a night shift and you receive a handoff from a person who's been taking care of the patient during the day. They leave and now you're the person in charge. Similarly, when you end a particular rotation, you give a handoff to the person who's coming on after you, and then you go off to a different assignment. So that's a handoff. Consultation is different. Consultation is more about teamwork. And just like this example of the baseball field, every player on this team has a different role. The person who's playing third base is not supposed to do exactly the same thing as the pitcher or the other positions on the field. And similarly, all types of consultation requests are not exactly the same. You may call a consult for several different reasons. And here's a bunch of examples that are listed on the screen. The ideal situation for calling a consult is you have a question that's outside your particular expertise, and you want to get the input from the specialist in that area. There's a clear question that's within their expertise that you're needing their help with and that they're able to help you with. That's kind of the ideal situation. There's several other things that you'll experience. Sometimes consults are obligatory, right? Here during the COVID-19 pandemic, initially we have had mandatory consultation with the Infectious Diseases Service for all patients diagnosed with COVID-19. Sometimes the request is procedural, and so there's a specific procedure that's needed. For example, a patient may need an indwelling catheter, and you would consult the procedure team, the procedure service for that specific procedure. They may or may not be asked to provide any medical decision-making around whether the procedure is the best one indicated, but simply asked for their technical expertise. An SOS consult is sometimes a reality, especially in ICU medicine, where I practice a lot. Is sometimes a person has a concern, they're not quite sure how to frame the question, but clearly they're asking for help from the consultant. Sometimes consultation requests are sort of confirmatory, which means you're seeing a patient, you've made some management decisions, but you have some lingering uncertainty, and so you're looking for a consultant to help you navigate that uncertainty and decide if your decision really is good to continue with or maybe needs to be altered. There are times when consultation requests are inappropriate. It's inappropriate to make a consultation for something that is not indicated. In our example of the indwelling tunneled catheter, it'd be inappropriate to ask for that intervention to be done in a patient who has very easy peripheral IV access that's adequate for their needs. Sometimes consultation requests can be made in an attempt to shift risk to a different person. The example for this might be a patient with atypical symptoms of chest pain who you feel is low risk for coronary ischemia, and yet maybe the cardiologist would be consulted in this case really just to make sure that in case something does happen, and a very small chance of that, at least they're not going to come after me, they'll go after the cardiologist. Clearly, if that's the reason for the consult by itself, that's not appropriate. There are also consultation requests known as curbsides, which I know you've done, we've all done, and they're not wrong to do. But a curbside is not a formal consultation request. It's really just a question of your specialist or of your consultant about a particular question. Somebody may grab me and say, hey, Dr. Miles, tell me, what do you think about this new inhaler for COPD? Do you think I might use it in this patient? Those general information requests are fine. The consultant just needs to take care not to be too specific in the recommendations for a specific patient if they haven't made a full evaluation of that patient. Now, effective consultation is not always easy, right? And a couple studies that I've listed here highlight some of the key factors. One of the biggest barriers is when the question is unclear. In this study from 1978, there was a diabetic consultation service in an academic medical center, and they looked, of course, this was paper chart time, and so consultation requests were just written as orders. And in 24% of the cases, there was no question even asked. It just said, consult diabetic service or consult endocrinology. What's even more interesting is that in about 12% of the cases, the consultants who gave the consultation, who reported on the consultation, completely ignored the question that was asked by the team. So you got to have good clarity around what's being asked and what you're answering. Incivility can be a big problem. An important study by the Canadian Medical Protection Agency in 2002 looked at factors that created intimidation for practicing clinicians. And it turned out the most likely source of that intimidating behavior came from other doctors. So even though we may be busy, we may be at stress, it's important to remain civil as we interact with one another. It's best for our patients and it's best for our care for one another. So what can affect the conversation that happens when consultation happens? There's an interesting qualitative study that was done, and I'll review with you briefly here, that looked at sources of tension when doctors are talking to one another on the telephone for a consult. This particular study looked at infectious disease consultation from a referral center to kind of outlying hospitals. But the lessons learned are applicable for just about any environment. And these 5 things came out to the fore as factors that created tension in this doctor communication. The first one is discursive features. Right? Discursive is about speech. Sometimes it was difficult to hear or difficult to understand the other person. And so we need to take this in mind. Is there a lot of background noise where you are when you're calling? Are you on your cell phone and walking through the sub-basement, and so the connection is spotty? Maybe English is not your first language or not the first language of the person on the other line. Be attentive to diction, be attentive to how quickly you speak. This is often an easy thing that we can improve by simply choosing a different phone, choosing a different location, or slowing down in our speech. The next thing here is context. Context is almost completely absent when you're talking on the telephone. What do I mean by that? It means when all you have is my voice, you have no idea what's going on around me, and I don't know what's going on around you. The person who's making the call often feels like their request is very urgent and very important, and maybe something where they're not sure what to do, and they have a high degree of anxiety about that. The person receiving the call, maybe they've had 30 calls that day with the exact same question. And so to them, this is an incredibly routine and rather unexciting question to be answered. both people in that circumstance need to understand the context of the other person can affect tension in that communication. And so we need to give each other the benefit of the doubt in what might be going on around it. Realizing talking on the phone to one another is not the only thing that we're doing today. There's lots more happening. And so we want to be respectful of one another and be efficient in the way that we talk and the way that we speak. The next thing here is the fragmented clinical process, right? If you're being asked for an opinion, especially only via the telephone, then it can be difficult to make a clinical decision when you're not actually seeing the patient. Or, for example, when maybe you don't have access to that patient's medical record. This is most applicable when you're taking calls from another hospital system with whom you don't share an electronic record. You know, as we all evaluate patients, we've become accustomed to our own process of looking through the chart. You know, I know where I like to click in Wake 1, for example, to look at microbiology results. I know how I like to get to the x-rays. You probably have your own way. When we're talking to someone on a telephone, we don't have access to those things a lot of times. And so what happens is often the person who's receiving the call will begin to ask very specific questions about lab values, about x-ray findings, maybe about physical exam features of the other doctor. And of course, the doctor who made the call and has the patient in front of them may feel somewhat threatened or may feel that they're not being trusted when that person is asking those questions. They may think to themselves, well, why does this person want me to tell them about the belly exam? Don't they trust that I believe this patient has appendicitis? Or why do they need to know the blood gas values? I mean, I told them that the guy had respiratory failure. I want to encourage you, rather than viewing that circumstance as one in which the consultant is distrustful of the caller, instead recognize that consultant is trying to match their own mental process to the data that they have. In short, they're trying to treat your patient the same way that they treat all the other patients. They're just trying to get the data into their mind in a way that they can think about it and help give you a good recommendation. Now, as consultants, we need to be sensitive to the fact that maybe I don't always need every bit of data to answer the question that's being asked of me. And so it comes back to the beginning. What's the question here? Let's talk about responsibility. This will be a little briefer, but the responsibility tension in a doctor conversation by telephone really comes into, you know, who's making the final call here? Who's making the final decision about how the patient is treated or what happens with the patient? Sometimes consultants can feel very weighed down by this, particularly if an outside hospital's emergency room calls asking for recommendations on a patient that they may potentially plan to return home or discharge with a certain treatment plan, and they're asking the consultant their opinion on that treatment plan. As a consultant or as a physician who's not actually examining that specific patient, it can feel challenging to give strong recommendations about a patient that you haven't examined. And that's correct. We need to refrain from doing that and realize our responsibility is not necessarily to be specific for that patient themselves when we're not examining them. What I generally say, and the way I approach this, is to give more general recommendations for patients in that circumstance. So let me give a simple example. Say a physician from an outlying hospital calls for recommendations on a very severe COPD patient who they've seen in their emergency department 6 times in the past 3 weeks with continued episodes of COPD exacerbation and symptoms that won't resolve. Patient's not too sick to be admitted to the hospital, but the ER doctor wants something else that they can do to help reduce the patient's frequent exacerbations. Now, as a pulmonologist, I would say there are several things that we might do for patients to reduce the frequency of their COPD exacerbations. And I would gain more information about what's going on with that patient. I'd like to know their current inhalers. I'd like to know their current other medications that they may be getting for COPD. And I might make a recommendation like this. You know, thanks, Dr. Smith, for calling. Based on what you've told me, it sounds like this patient has very severe COPD, and frequent exacerbations. Often in this type of situation, we'll consider using daily azithromycin, 250 milligrams once a day, as a way to reduce the frequency of exacerbations. I'd recommend the patient be plugged in and follow up with a primary care physician or a local pulmonary provider. We'd also be happy to see the patient in our clinic here for in-person evaluation and some further recommendations. But in general, for patients like that, I would consider daily azithromycin. And so that gives the person some more information from a specialist standpoint, and really is not the same thing as you saying, for your patient today, I would prescribe this. So it is a little bit of a subtle difference, but it can help if you as a consultant feel tension about maybe placing too much of your own responsibility in that patient's care. The last thing here is the reason for the call. This gets back to where we started, right? When you make a request for a consultation, it's important to know what's the request about. And if the caller and the consultant don't understand or don't have a shared understanding of the question that's being asked, then either that question will not be addressed, or maybe some other question will be answered that the person never even really needed to know. So in the last part of the talk, I want to go over 3 tools that you can use to reduce tension in the conversations that you may have with doctor-to-doctor consultations. The 3 tools here we'll go through one at a time. Let's start with the Bluff. And the Bluff stands for bottom line up front. It's a communication strategy actually used often in the military and in plenty of other settings, where you intentionally lead with the most important information. This is starting the call with the specific question that you have. Bottom line up front. Hello, doctor. I'm calling today with a question about a patient with COPD who's having frequent exacerbations. Bottom line up front. So the person who's listening already knows, okay, this is what I'm going to be listening for to help answer that question. In the field of journalism, this is known as the inverted pyramid. If you look at headline news, if you look at things in the newspaper or other articles, you'll notice often the most newsworthy information is either in the headline or the first couple sentences of the article, of the news story. That is the most important thing to help people know, what is this segment, what is this thing all about? Am I going to bother reading past the first paragraph or not? Now, once you get past the bottom line up front, I recommend using the S-bar to fill in some of the details behind that. S-bar is a communication format that you may already be quite familiar with because we use it often in clinical medicine. In fact, our nursing colleagues are probably trained much more on this than we are as physicians. And if a nurse calls you with information or a request about a patient, they will probably already be using this format to communicate with you. But you can see S-bar stands for situation, background, assessment, and recommendation. The only small change that I would make when we apply this to the consultation phone call would be change that R to the request. Because remember, we started out at the beginning with that bottom line up front. Now we're going to say some detail about, hey, here's what's going on with the patient right now. Here's the current situation. Maybe here's some vital signs. Here are the things that we've tried. Here's the background. Well, where did we start with the patient? What came in before this? What has contributed to what's going on right now? And you want to give your assessment as the caller, right, to the consultant. Hey, I see this patient with a pleural effusion, and I think that they may have an empyema, and this is my concern. And then finally, you request your final. You end with your request. And I need your expertise because, we don't have a thoracentesis trained person on site, and we think that may be necessary, or maybe even a chest tube. Can you come and give us your advice? So appeal to that person's experience. I mean, you're calling them because they have some experience or they're expert in some area where you're not, or you're looking for reassurance in an area. So appeal to that, and that'll help you get a good communication made to the consultant and have better interactions there. The last tool I would use I think is probably more important for the consultant. Often when the caller, the requester, is giving you information, they can be helped to know that you're listening actively, right? And repeat back is a great way to demonstrate active listening. This is when you communicate back to them and say, okay, I'm hearing you. You close the loop in the communication. You say, oh, okay, I'm hearing you. You got a 65-year-old gentleman with a diagnosis of COPD. Or, oh, okay, I'm hearing you that the pleural effusion does seem to layer when you get a lateral decubitus. Just repeat back some of the key points that the person's telling you to not only verify them, but helps you make sure that you're on the same page. So let's go back to that little scenario we talked about at the beginning. 4:30 p.m., Friday, July 3rd, 2020. You've got a patient that you've been working with all day, you think may need to go to the ICU. Take 10 seconds, and you can pause the video if you want, thinking about the factors that we discussed. And just think to yourself, what's a little script? How might you use the bottom line up front, a reason for this call, an S-bar, and how might you communicate with the ICU fellow to help diffuse some of that situation? Take 10 seconds and just think through that with me. All right. Well, I hope that that's been helpful. In closing, I've got a couple of slides that show you some advice that I would just give, and then we'll end with some questions that students in past years have asked on this topic. So, if you are the person requesting the consultation, here's a few points to remember. Whenever you can, it's always best to make consultation requests in person. The telephone suffers from several difficulties, such as context, discursive problems if the connection is poor. So if you can be in person, gosh, you're going to capitalize on all of our communication that's nonverbal, show your interest and your care for the patient with the consultant. Speak clearly. Use people's names. Nothing sounds quite as good to somebody as the sound of their own voice, right? So use their names. Help to have good communication. Use the bottom line up front. Provide those key features and repeat that question. The S-bar approach here. Now, remember, the consultant may ask for additional information, specific things, vital signs, lab values, findings of your exam. Remember, they're trying to piece that patient into their own thought process. They're not distrusting you. Don't feel offended if you're asked for those things. If they repeat or cover things again, just confirm that with them with a read back or a confirmation. That's correct. Now assume that they think about this differently than you, right? That you may be the third baseman and they're the center fielder. They have a different view. They're going to approach things a little bit different, and that's okay. That's why you're not both the same team member. You're different members of the team. In the case of the requester, really, and the consultant, just remain humble, remain engaged, and you'll learn and take greater care of your patients. If you're the consultant in this role, again, being in person is best. This especially holds true for communicating recommendations after the fact. If you've gone and evaluated the patient, if you can provide those recommendations in person, it's so much more helpful, because then a dialogue can occur about how to implement or maybe reasons that we may modify those. Speak clearly. Use names. Try to identify the question you're being asked in the sense of the consult type, right? Is this a attaboy consult where the person is just looking for confirmation of what they've already planned? Do they have a specific question in your area of expertise? If they don't give you a clear question, it's okay to ask for it. Ask, say, I want to help you the best I can. Can you give me a more clear sense of what exactly, how I can be helpful, what question I could answer for you? Be an active listener. Appreciate that the person calling you has a great deal of expertise of the patient who they've seen. And if you need to ask for more information, be transparent about that. Maybe be specific. I'm really thinking hard about this patient's likelihood of infection. Would you please share with me some of the details in the labs. Now, if you're only talking to them by telephone and you're not ever going to evaluate this patient, maybe they're distant from you, make your recommendations in a more general sense. You know, for most patients in this situation, here is an approach that we would use. You don't have to get real specific on an individual patient that you're not examining. Now, if you were asked a specific question, try to make sure that you do answer that question. Realize that being asked for help is an honor to be brought onto the team and be part of the team, but you certainly don't have complete perspective. And so if a requester takes your recommendations and follows only some, or maybe follows none of them, try not to take it personally. There's obviously competing interests with every patient, maybe reasons why that plan needs to be modified. And also the corollary to this is sometimes all of us are the requesters, right? We may need to ask for help in the future, so we certainly don't have clairvoyance. Collaborate as the consultant. Collaborate with the person who called you on the follow-up plan, especially if they're in your local hospital. You can even, if you can speak face-to-face, collaborate on how you'll follow up and what the next steps are that you'll take. So again, here's that list of the different type of consultation requests, just to give you a glance through. And I want to close with several questions that were asked by your colleagues in previous classes after follow-up of this lecture. And I'd also interject here and say, if you have questions, feel free to email me. I'd love to give additional answers to those. If it's okay with you, let me know, and I will also share my answers to your questions with the rest of the class so they can benefit. Let's go over these. So how do I construct a text page when I'm calling a consultant? Well, you want to make these brief, and you need to realize, depending on where you work, your hospital may or may not allow you to send protected health information, like a medical record number, in a page. So be aware of that. But the key thing, no matter what those rules are, is you've always got to put a callback number. You've got to put in some way for the person who has received your page to get in touch with you. That could be a telephone number, like this 867 number that you're going to be at that phone for a few minutes. And I would also suggest that you include your pager extension. Again, however it's formatted in your hospital. Here at Wake Forest, our pagers extensions are all 4 digits. And so you can see the templates that I have there for you. If you have room to put in the brief reason for the page, put that in there too. That just helps the person as they start to think about calling you and talking about this patient. Another question, should I use my title or should I just use my familiar name? Should I say, yeah, I'm Dr. Smith, or should I just say, hey, I'm Joe? What I recommend is when you're talking with a colleague, and by that I mean, a person, a fellow physician, then I would just say use your first and last name. Most physicians will be on the familiar name basis with one another, especially if you're within the same training program and same institution in a hospital. You might be a little more formal if you were speaking with a physician outside your institution who you're speaking to about a consultation. If you use your familiar name, include your level of training and what service you're working with. This is not to give you an out. This is just to make sure that the person who you're talking to knows who they're talking to and what your perspective is, kind of where you are on the field of the team taking care of this patient. I was asked, should I lead with a question when I call a consult? And the answer is absolutely, right? We want that bottom line up front. Start with the question. That helps the person you're talking to begin to think already in the way that they can answer that question. And then you can provide those clarifying details in that SBAR format. So that here's an example of the first sentence that you may come out of your mouth when you're calling a consultant. Here's one. What do I do if someone's being rude to me? Is it okay to recognize that, to call that out? Absolutely, right? You should never expect, it should never be part of a acceptable culture to be rude or short or uncivil with other physicians, really anyone, when talking on the telephone, right? What your mama taught you about talking on the phone is still true. Now, it is helpful to realize that this creates a lot of tension in a phone call conversation. The first thing to do is, okay, check your own reaction. Take a deep breath, realize you can't see their surroundings, right? You don't know what was happening in the 2-3 minutes right before they had to call your page back. So give them a little bit of the benefit of the doubt. Maybe that person you're talking to is struggling with burnout in that moment. It's okay, though, to address if this person's being rude. Instead of just pointing it out necessarily in a confrontational way, start with a question. Here's some examples of how you might do that, escalating it a little bit more each time. Sometimes that doesn't solve the issue, and the person continues to be rude. And I would say certainly in you guys' experience coming up as interns, you should feel ready to escalate this if your initial attempts are not helpful at diffusing the situation, especially if a person has unreasonable criticisms that they would make for an intern compared with a more senior person. They should not have that, but if that happens, then escalate that to your senior resident, fellow or attending, and just let them bear the brunt of that person's bad conduct. So in closing, remember, consultation is teamwork. Everybody on the team taking care of this patient has a slightly different perspective, has a slightly different role. Hopefully the communication tools that we talked about will help you make the most effective use of all the team members, no matter what your role is in their care. Here's a few suggested readings, and as I said at the beginning, we're living in a unique time. I'm proud to be able to speak with you. I'm proud of you all as graduates of Wake Forest School of Medicine, and I know you're going to do great things. If I can help you in that journey, or if you have questions about this talk, feel free to shoot me an email, and good luck to you.